So this morning I'm going to be talking about secondary open-angle glaucomas, which are not so good, often bad, and very occasionally very ugly. So I have no financial disclosures. So the secondary open-angle glaucomas are a large bag. We all know what primary open-angle glaucoma is, where we have physically open angles but develop glaucomatous changes. So secondary glaucoma involves identifiable causes. Okay, so there are a number of them. So we're going to go through pseudoexfoliation, pigmentary dispersion, lens-related glaucomas, inflammatory glaucoma, traumatic/surgical glaucoma, tumor-related, elevated episcleral venous pressure, and steroid-induced. So let's go through some scenarios. So this is my first patient. Can we have the lights down a little bit in front? Perfect. So this is my first patient, who is an elderly woman originally from Sweden. She comes in complaining of poor vision. Her vision in the right eye is 20/80, left eye 20/50. On exam, we notice that she has a pretty large cataract in both eyes, more so in the right, with some white flakes on the anterior capsule and a second ring of flakiness on the inside part of the capsule. She does not, well, this is her left eye, so she dilates a little bit better in the left eye. Her right eye does not dilate so well. Her intraocular pressures are elevated in both eyes, more so in the right, 27 than the left, and she has some moderate cupping in both eyes. So any ideas from anyone in the audience what this could be? Correct. All right, pseudoexfoliation syndrome. Which is actually due to a mutation in the gene locus LOXL1, which leads to abnormal elastin fibers. So pseudoexfoliation material is actually found throughout the body, including the skin, the heart, liver, and kidneys. In the eye, we see it as a whitish gray fibrillar material, and we see it deposited everywhere, especially on the lens epithelium and capsule, but also on the pupillary margin. And it's also been found in ciliary epithelium and the iris tissue, as well as subconjunctival tissue. So historically, it's always been thought that pseudoexfoliation basically does its only damage in the eye, but it actually has also been associated with heart attacks and strokes, as well as high blood pressure. So clinical experience, like we had in our previous slides, we see flaky material on the lens, historically, or two zones. So you'll see it on the anterior capsule, usually see it better after dilation. So you'll see a center ring of flaky material and then a more peripheral ring. And again, you can also find it very commonly on the pupil. So if someone is pseudophakic and you don't have a lens to look at, you can find flaky material on the pupil. Pseudoexfoliation causes glaucoma in two ways. One is a direct deposition of the fibrillar material within the trabecular meshwork and uveoscleral pathway. And also the elastin abnormality can actually cause the lamina to be weak, so it does lead to increased optic nerve susceptibility. So again, just to look at the picture of it, it's a really super classic picture with the peripheral flakiness and then the central zone. So why do we even care so much about pseudoexfoliation? Well, it's a pain to deal with. But this is the angle in pseudoexfoliation. So there's the normal angle here. You have your Schwalbe's line, and then the non-pigmented trabecular meshwork, or the anterior TM, the pigmented TM, which is posterior pigmented trabecular meshwork, and then the scleral spur and the ciliary body band. The angle in pseudoexfoliation is pretty characteristic. We have this pigmented band up here, which is the Sampolisi's line. Can be found in other glaucomas, but very characteristic of pseudoexfoliation. And then the TM pigment is very patchy. It looks kind of like salt and pepper pigmentation. And the angle is usually open, especially early in the course of the disease, but it can become narrow over time. So these patients need to be watched for development of narrow angle and sometimes need treatment for that as well. So pseudoexfoliation, as we all know, or anybody who's done cataract surgery, is the bane of our existence. It does lead to faster cataract progression, but these patients also have poor dilation, so it can be a very tricky cataract extraction. It does lead to a weakened zonule, so even if it doesn't seem to be clinically wiggly. Like you'll see the actual cataract sometimes doing this, dancing around. We know that once you get in there and try to do anterior capsulorhexis, it can be very challenging. This can also lead to intraocular lens dislocation years later. So as we have an aging population and we're seeing people who've had cataract extraction done 20, 30 years ago, we're seeing this increasingly often where posterior chamber lenses are actually dislocating and dropping into the posterior chamber. So I've talked to a number of my retina colleagues who are seeing this much more and more often. So it's also something always to watch for. So the prevalence is very high, especially in Scandinavian countries. 50% of glaucoma in the Scandinavian area is due to pseudoexfoliation, though it really is all over the world. 10 to 20% of people over the age of 60 actually have pseudoexfoliation. It's rare to see it in younger age groups. And it's just, as anybody else, again, who's dealt with it, it's really can be very difficult to manage. Much more so than primary open-angle glaucoma. Sudden intraocular pressure spikes are not uncommon, and you can have a patient that you've monitored for years who've done very well, and then one eye and then the other eye suddenly go out of control. It is very amenable to selective laser trabeculoplasty, though that's often not enough. Topical medications, of course, but many times these patients do come to incisional surgery because it just tends to march on. Okay, so we'll turn to, so I'm going to hold all questions to later on. I'm happy to answer any and all, but we'll do them later. So this is my second patient now. It's a young man, or youngish man, who complains of worsening night vision. He notices he has some cloudy vision every time he plays basketball. His vision with a -3 correction is 20/20 in both eyes. His intraocular pressures are somewhat elevated, 25 in the right, 26 in the left. On exam, we notice he has a pigmented stripe on his corneal endothelium, and also we notice some pigment on the anterior capsule, as well as some mid-peripheral transillumination iris defects, and he has some moderate cupping in both eyes. So let's look at some representative pictures. So on the left, he has an endothelial stripe of pigment, and then we can also see some of these mid-peripheral transillumination defects. So what do we think is going, well, first of all, does anybody know the name, or I'm sure you guys do, of this, this little corneal finding? Correct. And so what is this entity? Correct. Great. I don't know why I'm here. So, okay, so this is a pigmentary dispersion. So the classic academic book thing is for young myopic males, but we do also see it in females. The hallmark is really very wide fluctuation in intraocular pressure, especially after dilation or exercise. People complain of halos and blurring, which is really due to steamy corneas. And the mechanism here is that the iris is bowing posteriorly, and it is causing a reverse pupillary block with an increased contact with the zonule. So the zonule is literally rubbing the pigment off of the back of the iris. So again, in pigmentary dispersion, we have that Krukenberg spindle, which is really characteristic of pigmentary dispersion. And we can also see, not all the time, the peripheral spoking or transillumination defects in the peripheral iris. Also find pigment all over on the lens periphery and trabecular meshwork and on the zonule, which you can see if they're well dilated. And the angle has an extremely heavy, really uniform pigment. So unlike pseudoexfoliation, where we had that kind of patchy pigment, pigmentary dispersion, especially in the inferior angle, is this just really heavy band. So how do we treat this? Usually it's amenable to medical therapy. 30 years ago, we often treated people with pilocarpine because we basically kept the pupil from moving around and rubbing against the zonule. There was something called Pilocert, which sadly doesn't exist anymore, but it was something that it was a little pellet that we put into the inferior fornix, and it was a slow release of pilocarpine over time and very useful. We can also they're also very amenable to SLT, or selective laser trabeculoplasty. It can have a short-lived effect, but it can also be repeated, which is helpful. With the SLT, however, one does have to be careful because you can actually liberate pigment during treatment. So we tend to be a little cautious when doing an SLT, and would do maybe we'll talk about SLT at another point, but when we do SLTs, we're oftentimes treat a 360 angle, but with pigmentary dispersion, and especially in a heavy angle, I wouldn't do more than 180 to prevent a pressure spike. So not everybody who has pigmentary dispersion gets glaucoma, but they should all be monitored for development of glaucoma. And you can also actually outgrow it over time. As the lens gets fatter, it pushes the iris away from the zonule and essentially eliminates the ongoing process of pigmentary dispersion. So the signs can actually disappear over time. So let's now turn to lens-related secondary glaucomas, and these include phacolytic, lens particle, and phacoandrogenic. So our next patient is an elderly man who comes in complaining of pain, and he has dramatic redness in his right eye. He has poor vision in both eyes, but it's been worse recently. And as we can see, his vision is very poor in the right eye, hand motions in 2300 in the left. He has a very high pressure in the right eye as opposed to the left. And on an exam, we see he has a hazy cornea with and a red eye, no KP, but he has some cell and flare with clumps of material floating around and a wrinkled anterior capsule with a dense cataract. So again, wrinkled anterior capsule, dense cataract behind it, some anterior synechiae. What do we think is going on here? He's got phacolytic glaucoma, which is pretty uncommon, I'll have to tell you, but it is actually from lens proteins that are leaking from a hypermature cataract. We don't see this very much, especially in developed countries, but the angle becomes clogged with protein and inflammatory cells. And the nice thing is it's very amenable to treatment. We take out the cataract and their glaucoma goes away. So this is a nice schematic from the AO where we can see macrophages that are actually physically clogging the angle, and a little schematic here showing lens proteins leaking out and causing this inflammatory reaction. So my next patient had a cataract surgery a week ago, and you were seeing it as a resident, and you see the notes from somebody else that said it was a difficult surgery and that some cortical material was left behind. The first day, vision was actually very good, and it has now dropped a week later, and the pressure is high at 33, and we see an inflamed eye with a lot of cell and flare and some cortical pieces floating around the anterior chamber with some synechiae. And the dilated exam also shows some retained cortex. So here on the left, you can see there's some copious amounts of cortex in the anterior chamber, and then also we see some cortical chunks floating around in the vitreous in the posterior chamber. So this is lens particle glaucoma, which is not uncommon, especially if cortical material is left behind, and it can happen after cataract extraction. It can also happen with a YAG capsulotomy if we've liberated material that way, and through trauma. And literally the cortical materials are just, the particles are just blocking the meshwork, and you get an extreme reaction. Most of the time this can be treated with time, with steroids. May need to obviously control their pressure with drops, and this is almost the same way we would treat a uveitis. If it becomes hard to manage, especially on the intraocular pressure front, taking out those cortical material will basically solve the issue. So our next patient is a young man who was hit in the eye during a squash match a week ago, and now he's complaining of pain and decreased vision and a red eye in the eye that he was hit in. His vision is excellent to his right, very poor in the left, with a high pressure in the left eye. And we can see on his exam that he has some, well, he obviously has a red eye. He's got some mutton fat or granulomatous chorotic precipitates there. And he has synechiae and a vitritis on exam. Anybody know what this one's called? Yeah. So it's phacoandrogenic or phacoanaphylactic glaucoma. This is rare but very acute, and what happens is either from trauma or from surgery, there are lens proteins that are exposed into the eye and causes a granulomatous inflammation. So we'll see big fat, mutton fat KP on the endothelium and in the anterior capsule, and you can have a vitritis and synechiae. So here on the left, there's actually a corneal scar and then lens protein being exposed, and that's what's causing this macrophage reaction. Right, and there's a lens protein again. So the treatment is steroids, and usually we're going to get to surgery to remove the lens, and that will take care of the issue. So let's turn now to the uveitic glaucomas. These include Fuchs' heterochromic iridocyclitis, Posner-Schlossner syndrome, or glaucoma cyclitic crisis, and JRA, or juvenile rheumatoid arthritis. So my next patient is a middle-aged woman who has noted that her left eye has actually become lighter over the years, and her vision is fuzzy. Her vision is 20/40 in the right and 20/80 in the left, where she's noticed that her eye has become lighter. Her pressure is higher in that same eye. And on exam, the right eye is normal with a brown iris and early cataract. And the left eye, we notice that she has very sort of fine KP on her endothelium. She has a much lighter iris than the other eye, and a little bit of cell reaction. And she also has not just a early cataract, but she also has a PSC cataract. Very good, yes. So this is Fuchs' heterochromic iridocyclitis, where we see iris heterochromia due to loss of iris pigment. So brown eyes actually look lighter and blue eyes get darker. There's an equal prevalence between middle-aged men and women, and you get a low-grade cellular reaction. The eye is not particularly inflamed looking at all. But the glaucoma can be very difficult to manage, and it's a much more aggressive glaucoma than the inflammation would suggest. In the angle, you can see there are these fine blood vessels, which in and of themselves are not actually dangerous, and we don't actually create any synechiae, but these blood vessels can be a hassle if you're trying to do cataract extraction. And also would mean that this is not amenable to any sort of laser therapy. You don't want to go anywhere near those. Glaucoma occurs in about 15% of eyes that have the lighter iris or the affected iris. And again, this can be hard to control, and we can't control it with steroids. And it is thought to be possibly due to rubella virus. So nobody's really sure why this is happening, but it can be a challenge to manage. Not very common, at least not common in New York. I don't have a patient for this, but this is Posner-Schlossman syndrome, or glaucoma cyclitic crisis. It's rare, and what we get here is some acute, recurrent, very mild anterior uveitis with a way out of proportion pressure spike. And these can kind of be sort of very intermittent, and the pressure spike can last from days or longer. And then in between, people are pretty much normal. And we'll get these sort of, didn't want to do that. We'll get these fine, like medium-sized KP on the cornea, which can actually disappear in between. The presentation can vary a bit, but usually people have blurred vision from corneal edema. They can have some eye pain. Interestingly, the cupping can be reversible, especially initially. You might find cupping during the acute attacks, and then the cupping is reversible, but then over time, of course, the cupping becomes permanent. And again, this is not really sure what's happening. They possibly due to CMV virus, and also is it a trabeculitis, or are there increased prostaglandins in the aqueous causing this pressure spike? But either way, we sort of just treat it symptomatically. Obviously, we're treating their glaucoma and with steroid drops. And then lastly, in the uveitic glaucomas, we'll just talk a little bit about JRA, or juvenile rheumatoid arthritis, which is the #1 cause of childhood uveitis, and many patients do develop glaucoma. The problem with the juvenile rheumatoid arthritis and their uveitis is that these eyes don't tend to be super inflamed, and it can actually be missed if patients, because these are mostly like younger kids and they're not necessarily complaining. And so these kids, these young people do need to be followed carefully to make sure they're not developing secondary glaucoma. And as you can see, they also develop other chronic issues like band keratopathy and other signs, synechiae, and other signs of chronic inflammation. So the treatment would be meds, of course, and then they often come to needing glaucoma drainage devices because it can be difficult to manage. And ironically, of course, with any uveitic glaucoma, we're treating them with steroids, but the steroid can make their eye pressure go up. So it's always a little bit of a balancing act. So the uveitic glaucoma is just in general, right? What's happening here? So originally, initially when you have uveitis, your pressure is usually low because of ciliary body shutdown and increased uveoscleral outflow. But then later on, as the trabecular meshwork develops dysfunction and you get this damage caused by all the inflammatory cells and the proteins and debris and fibrin, their pressure will rise. And then cytokines can just exacerbate the inflammation and also lead to neovascularization. And of course, we treat uveitis with steroids, but they can also worsen the intraocular pressure control problem. So it becomes this kind of vicious cycle and can be very challenging to manage. So let's turn now to traumatic glaucoma. So there are many types of injury can lead to glaucoma, and glaucoma can be due to either direct injury to the trabecular meshwork or inflammatory cells, debris, and blood blocking the angle. It can also occur with chemical injuries such as alkali injuries, which cause inflammation and shrinkage of the trabecular collagen. And then a side note, so siderosis, which we don't see too often, but is interesting. It's due to a retained intraocular metallic foreign body, especially those with a low redox potential, such as iron and copper. And these breakdown products can actually accumulate in trabecular meshwork and lead to a secondary glaucoma. So most of you guys have probably seen a hyphema. So hyphema is obviously blood in the anterior angle, and it is secondary glaucoma is, or ocular hypertension is very common. Secondary glaucoma is more common with a rebleed, and a larger hyphema implies a larger risk of intraocular pressure spike. Sickle cell hemoglobin carriers have a higher risk of glaucoma even with a small bleed because those cells are rigid and they just block the trabecular meshwork. And the optic nerves in patients with sickle cell also tend to be more susceptible due to microvascular perfusion or low microvascular perfusion and tend to develop secondary glaucoma as a result. So the way we treat this is rest, steroids, topical therapy, cycloplegia, and I put questionable aminocaproic acid. We don't use it that often, but it does stabilize the clot and decreases the rebleeds, though it is hard for patients to take, and it's associated with nausea and vomiting and hypotension, and you can't use it in people who have renal disease or hemophilia. The treatment for this ultimately, if their pressure is not being well controlled, is to do anterior chamber washout, and that tends to solve the problem. So hemolytic and ghost cell glaucoma is another type of blood-related glaucoma where this is actually coming from the posterior chamber after a vitreous hemorrhage. So red blood cells actually need up to 3 months to degenerate, and they can actually access the anterior chamber through a disrupted hyaloid face. And so it causes glaucoma in a couple of different ways, but mostly it's just physical clogging of the trabecular meshwork. So the hemolytic glaucoma is when you have hemoglobin-laden cells that are reddish brown, and then ghost cell glaucoma are tan cells, and they have the characteristic Heinz bodies, like that little red dot there, and those can also clog the meshwork. So you can see that the eyes they're pretty quiet, they don't tend to be inflamed. You'll see kind of junkiness floating around with the tan cells, a lot more cells in the chamber than flare, and the eye, again, doesn't tend to be red or inflamed, but the pressure can be really high. If you look at their angle, you'll find ghost cells layering inferiorly. And the treatment is generally topical. We can sometimes ride it out. The ultimate therapy would really be a vitrectomy to remove the blood back there if things are not resolving quickly. So angle recession glaucoma is another one that's, again, due to oftentimes a blunt injury, and it's associated, what happens is it causes a tear in the ciliary body between the longitudinal and circular muscle fibers. There's an associated secondary injury to the trabecular meshwork, and so the degree of angle involvement will actually give you sort of increased risk of glaucoma. Glaucoma the risk tends to decrease over time, but it's never zero, and these patients should be followed and be warned that they need to be followed periodically, especially if they've had a hyphema. And interestingly, up to 50% of the other eye can develop glaucoma, which does suggest that there's probably a predisposition to developing glaucoma. So in angle recession, again, we have sort of like a broad angle recess with a widening of the ciliary body band. And you might see some sneaky at the border. So if you're not really sure what you're looking at, you always gonio the other eye. Because maybe they just anatomically, sometimes it can be hard to tell what's normal, what's not. So if you look at the other eye, you can use that as comparison, of course. So the treatment for angle recession tends to be usually medical. We're not going to use miotics. They don't tend to do well. And we're not going to use laser. They don't tend to do well with that either. And then, of course, may come to surgery. Okay, so speaking of surgery, well, let's talk about surgical trauma with glaucoma. All types of surgery can lead to glaucoma, but especially corneal surgery, full thickness corneal transplants, and the keratic prosthetics definitely lead to glaucoma, and really from direct damage to the anterior chamber and the trabecular meshwork, inflammatory debris, red blood cells, and then angle closure. And this can be immediate or delayed onset. Interestingly, I don't know how many people here have seen a K-Pro, which are these very cool little devices, or essentially an artificial cornea, but checking an intraocular pressure afterwards is almost impossible. So, and most of them actually, now we're starting to do a K-Pro always in association with a glaucoma tube, because we know these patients are just going to develop glaucoma. So we have an elderly man here who had cataract extraction earlier in the day, and my resident on call gets a phone call saying the patient is having a headache and nausea. What's happening here? Right. Somebody left viscoelastic material behind. So we get an immediate pressure spike, which can be very high, and it's usually about like 6 to 8 hours after surgery. These can be managed very easily. You can actually just burp the anterior chamber, and then just topical meds in time. But that is the reason why we try to remove viscoelastic material from the eye at the time of surgery. And then delayed causes of surgical glaucoma include the uveitic glaucoma hyphema syndromes, secondary pigmentary glaucoma, and then pseudophakic pupillary block, which is not an open-angle glaucoma, but that is when the lens obviously blocks off the angle. So the UGG syndrome, again, uveitis, glaucoma, and hyphema, we see these usually with older types of the anterior chamber lenses, like these ones that kind of grip onto the iris, though you can actually also see it with a malpositioned posterior chamber lens or suture-fixed lens. And basically what happens, you have chronic irritation and chafing, and then intermittent rebleeds. And this can lead to CME, or cystoid macular edema, and then secondary neovascularization and bleeding from that. And the ultimate therapy for this is lens exchange. I mean, it's not even worth fooling around with it because it's just going to keep on happening. So secondary pigmentary glaucoma is somewhat related in that lens chafing is also against the iris, but it's not causing bleeding. It's just releasing pigment, which is clogging the angle. And again, if this can't be controlled, removing the lens or exchanging lens will control it. So I threw this one in. This is extremely uncommon, but I think it's interesting. It's the Schwartz-Matsuo syndrome, which you get with a rhegmatogenous retinal detachment. And the risk factors are really if you have a large retinal dialysis at the ora serrata, or again, a large rhegmatogenous retinal detachment. And usually with a retinal detachment, the pressure is low, but intraocular pressure can actually rise if the photoreceptor segments find their way into the aqueous, and they can lead clog the angle and lead to high intraocular pressure. And the intraocular pressure normalizes once the retinal detachment is repaired. So tumor-related glaucomas, not so common, but we do see them occasionally. So the number one would be retinoblastoma, and that's in children. It's a nice picture of retinoblastoma. And also juvenile xanthogranuloma and medulloepithelioma. And adults, uveal melanomas, METs, this is a breast cancer medicine, and then lymphoma or leukemia. So how do tumor-related glaucomas, how do they occur? So they can occur from direct invasion into the angle. They can occur with posterior masses that actually can cause the ciliary body to rotate forward and cause a secondary angle closure. You can have intraocular hemorrhage that leads to our ghost cell and glaucomas. You can get neovascularization of the angle, and then tumor and inflammatory cells actually literally clogging the angle. So over here, really ugly picture of anterior segment melanomas, which would be direct invasion. Another one in the iris also causing direct invasion. And then the large posterior melanoma, which would cause the ciliary body to rotate forward and get a secondary glaucoma from that. So let's now turn to the elevated episcleral venous pressure. So patients with this have a very chronic, red, angry-looking eye with tortuous, dilated episcleral veins. And they may have a history of trauma, though this is usually idiopathic. It can be uni or bilateral, may have proptosis, and we can sometimes see blood in Schlemm's canal. patients may complain of a whooshing sound in their ears, and that is often indicative of a high flow fistula. So what are the causes? There are dural fistulas, CCV, or carotid cavernous sinus fistula, orbital varices, and Sturge-Weber. And so over here, there's actually a nice schematic from the AAO, actually no, this is from online, of a CC fistula. And then there's some imaging, and they're stenting it or embolizing it. And then this is the eye afterwards. So uncommon, but somebody who has a very chronic, especially if it's asymmetric red eye, should be evaluated. Then this is a nice classic picture of thyroid eye disease. And retrobulbar tumor can also cause, so thyroid eye and retrobulbar tumors lead to venous obstruction. So again, these are kind of just angry, ugly looking eyes. So really the treatment, obviously we're going to treat these like we would with any glaucoma, though we have to be careful because filtering procedures can be dangerous and cause a choroidal effusion or worse yet, a suprachoroidal hemorrhage. So again, this is blood in Schlemm's canal, which is a really classic finding. Really, you need to look for causes. What is, we want to make sure we're not missing something that could kill somebody, right? So you always want to make sure they're not, there's no fistula or anything else there. And we cannot, again, this is a glaucoma that is not amenable to SLT. So lastly, we come to steroid-induced open-angle glaucomas, which is one of my biggest pet peeves ever, because dermatologists and medical doctors like to prescribe steroids for almost everything, and many people do have a steroid response. So any type of steroid, oral, obviously eye drops, any ear drops, skin, a little bit on the skin distally, and then of course the inhaled drops, inhaled steroids can all lead to intraocular pressure spike. 1/3 of the general population will have a pressure rise. People with glaucoma tend to be much higher risk of developing that, and they can have a much greater pressure rise, up to 15 millimeters or more. And the risk factors, of course, well, if you have glaucoma, you have a higher risk of steroid response. But if you have a first-degree relative with glaucoma, obviously if you've had a previous steroid response, if you have angle recession glaucoma, high myopia, if you're a very young patient or a very old patient, type 1 diabetes, and connective tissue disease. So I always, anytime somebody comes to me who's been controlled in the past and suddenly has a pressure spike, especially in both eyes, the first thing I do is interrogate them about what they've been using, what they've been given, looking at their medical lists, what are they using over the counter, and it's amazing how many times people come and are using all sorts of steroid therapies that nobody's aware that can actually be causing a problem.